All right, so it's 1 after, and I want to welcome you all and thank you for joining the Applicant Technical Assistance webinar for RFA-MD 22-007, Community Level Interventions to Improve Minority Health and Reduce Health Disparities. My name is Crystal Barksdale, and I am a program director in the National Institute on Minority Health and Health Disparities, NIMHD's Division of Community Health and Population Science. Next slide. I would like to take this opportunity to introduce my colleagues who will be presenting and available during this TA webinar and available to answer questions. We have Dr. Deborah Ismond from NIMHD. We have Dr. Jennifer Alvidrez from the Office of Disease Prevention, and we have Dr. Eve Rader from the National Institute of Mental Health. Thank you all for joining us this afternoon. Okay. Before we begin the webinar and launch into this afternoon's information, I want to offer a few technical webinar tips and reminders listed on the slide. So first, Participants will be joining in listen-only mode and will not be able to ask questions verbally. We request that you submit your questions using the chat feature, and we will be monitoring that feature throughout the webinar. So as such, please enter your questions at any time during the presentation, and we will answer the questions during the Q&A session at the end of the webinar as time permits. These slides and a recording of today's webinar will be available on the NIMHD website for future reference at the link listed here. Next slide. Okay, so the following is an agenda for today's presentation and webinar, and I'm just going to go over that briefly. So first, we are going to provide some background information about this RFA and then describe the research objectives and the expectations. Dr. Ismond will then discuss the peer review process and provide a general overview of the review of applications. I will then discuss the timeline for submission, review, and selection of applications, and then we will turn to answer some of the participants' your questions. Okay, so let's jump in to part one and talk a little bit about the background. So before we do that, I wanted to provide a bit of grounding and discuss some key definitions, which are also included in the RFA. So first, when we refer to community, we are referring to a social group of any size whose members reside in a specific locality, share government, and often have a common cultural and historical heritage. Communities may be self-defined, such as the LGBTQ community in a city or county, or defined by the catchment area of a local government or service providers. For example, residents served by a county, school district, or community clinic. Examples of communities include, but are certainly not limited to, neighborhoods, towns, cities, counties, school districts, reservations or tribal communities, military bases, or college campuses. Virtual or other communities that do not reside in the same geographic location are not a priority for this initiative. Next, when we talk about a community level intervention, which we will discuss in more detail in a moment, we're referring to an intervention that modifies community characteristics, including the physical or social environment, laws or policies or practices of organizations or governmental agencies within the community, and or norms or collective behaviors of community residents. When we refer to community engaged research, we are referring to a research process of working collaboratively with groups of people affiliated by geographic proximity, special interests, or similar situations with respect to issues affecting their well-being. Community engaged research approaches emphasize collaborative partnerships with key stakeholders, such as community partners, leaders, and knowledge holders, and leverage community resources to achieve community benefit via the research process. Examples of such community engaged research approaches might include participatory action research, community-based participatory research, team science, empowerment evaluation approaches, community asset mapping, and citizen science. And then finally, when we talk about populations with health disparities or that experience health disparities, this is based on the current designation, which includes individuals who are Black, African American, or African American, Hispanic or Latino, American Indian and Alaska Native, Asian American, Native Hawaiian, and other Pacific Islander, and socioeconomically disadvantaged populations, underserved rural populations, and sexual and gender minorities. Next slide. So with that grounding, now I will provide a bit of background about this RFA. This community level interventions RFA was brought forth by previous work done via the NIMHD Community-Based Participatory Research or CBPR program. The NIMHD CBPR program was established in 2005 to enhance community capacity in research for which they would directly benefit by addressing the need for improved transdisciplinary collaborative intervention research, addressing health disparities, and strengthening the science of community engagement. With the implementation of that CBPR program, there were several projects funded that emphasized CBPR methods. An urgent, significant next step in advancing the CBPR program is prioritizing interventions that utilize community engaged research approaches and move beyond the individual level of target. Thus, NIMHD has identified an emergent need to shift from prioritizing individual level interventions to more structural level, multi-sectoral, and multi-level interventions. And in this case, specifically with this RFA, community level interventions to improve minority health and eliminate health disparities. Next slide. Therefore, the primary research objective of this RFA is to support research projects to develop and test prospective community-level interventions to improve minority health and decrease health disparities. So let me talk a little bit more about community-level interventions, since they represent the core of this RFA. As noted previously, a community-level intervention is an intervention that modifies community characteristics, such as the physical or social environment, laws, policies, or practices of organizations or governmental agencies within the community, and or norms or collective behaviors of community residents. On this slide, we depict and show the NIMHD research framework, with which you may or may not be familiar. The NIMHD research framework is a multidimensional model that depicts a wide array of health determinants relevant to understanding and addressing minority health and health disparities. These determinants may reflect etiological factors and intervention targets to improve minority health or reduce health disparities. The list of factors here is not intended to be exhaustive. Of relevance to this webinar is the community level of influence. Community level interventions would focus on the types of determinants, such as those listed under the community level of influence, such as community illness, community functioning, community environment, community resources, community norms, local structures and policies, availability of services, and the like. Next slide. Furthermore, when we think about and talk about a community level intervention, it employs, most importantly, community engaged research approaches. They modify community characteristics, but may also modify individual level characteristics. And again, most important and thus bearing repeating, they target community level determinants of health, such as those listed here. Next slide. So what does not constitute a community level intervention? An intervention that exclusively helps individuals address, cope with, manage, or navigate community level determinants without directly operating on those determinants. An intervention that is community-based, but that does not target community level determinants of health. An intervention that includes community-wide elements, but the intervention effects are only tested at an individual, or interpersonal or organizational level, would not constitute a community level intervention. And finally, community-wide outreach and recruitment of participants in interventions that are not community level would not constitute a community level intervention. Next slide. So with that detail about community level interventions, I turn now to discuss some of the expectations of community level intervention projects of this RFA. Specifically, community level intervention projects are to be led by or conducted in collaboration and full partnership with appropriate community partners, such as community-based organizations, faith-based organizations, or local businesses, and the like. Multi-sectoral collaborations involving partnerships with multiple types of organizations in the public and private sector are strongly encouraged. These projects are expected to focus on improving health outcomes or reducing health disparities in one or more NIH-designated health disparity populations in the U.S. They are also expected to focus on the entire population in communities or a specific population within communities. They're expected to collect data beyond individual self-report to determine how the intervention is impacting community-level determinants of health. They are expected to be guided by a conceptual model identifying hypothesized pathways between the community-level intervention, community-level determinants, and health outcomes. Next slide. These community-level intervention projects are also expected to prospectively test the impact of the intervention on self-reported or measured health outcomes. Retrospective analysis of existing or past community-level interventions or initiatives are not responsive to this initiative. The projects are expected to include health outcomes at the individual, interpersonal, organizational, or community level, or a combination. They're expected to use appropriate measures and analytic methods appropriate for examining community level mechanisms of action and health outcomes. And finally, they are expected to test interventions that have the potential to be sustainable in the community after project funding is over. So with that, I would like to share a bit about NIMHD's specific areas of interest. Next slide. So overall, NIMHD is interested in research that is aligned with its mission and the NIH Minority Health and Health Disparity Strategic Plan of 2021 through 2025, and utilizes community-engaged research approaches and the NIMHD research framework to assess and intervene on health determinants beyond the individual level at the interpersonal, family, organizational, neighborhood, community, and societal levels. Community level intervention targets of special interest include, but are certainly not limited to, Some of those listed here, including increasing affordable, healthy food options and opportunities for physical activity outside of the home, changing community norms and reducing structural barriers related to health promoting behaviors, such as breastfeeding, vaccination, physical activity, and preventive health screening, improving community attitudes towards socio-demographic groups or towards individuals with certain health conditions that are detrimental to the health and well-being of these populations, promoting promoting screening, detection, help seeking, and self-management related to acute or chronic illnesses, enhancing the ability of community dwelling older adults to age in place or individuals with disabilities to live independently and maintain the health and their well-being, promoting community reintegration and health of individuals returning to the community after incarceration, hospitalization, or institutionalization, and preventing accidental injury, violence, suicide, or suicide thoughts and behaviors. Now, I would like to turn it over to my colleague, Dr. Eve Rader, to discuss NIMH's areas of research interest. Dr. Rader?
Thank you very much. The National Institute of Mental Health is interested in applications relevant to priorities described in this RFA and that support the NIMH strategic plan for research. NIMH is committed to supporting research that reduces disparities and advances equity in mental health intervention services and outcomes. Applications proposing clinical trials should follow NIMH's experimental therapeutics approach to intervention, development, and testing. That is, the scope of work must include specification of targets, mechanisms, and assessment of intervention-induced changes in the presumed targets, mechanisms that are hypothesized to account for the intervention's outcomes. NIMH encourages a deployment-focused model of intervention and services design and testing that takes into account the perspective of relevant stakeholders and the key characteristics of the settings that are intended to implement optimized mental health interventions. This attention to end-user perspectives and characteristics of intended clinical and/or community practice settings is intended to ensure the resultant interventions and service delivery strategies are acceptable to consumers and providers. The approaches are feasible and scalable in the settings where individuals are served, and the research results will have utility for end users. NIMH encourages effectiveness research on potentially scalable preventive, therapeutic, and services interventions that focus on practice-relevant questions. Accordingly, collaborations between academic researchers and clinical or community practice partners or networks are encouraged. When possible, studies should capitalize on existing infrastructure to increase the efficiency of participant recruitment and to facilitate the collection of moderator data, longer-term follow-up data, and broader stakeholder relevant outcomes. Next, please. Here we go. So areas of interest include, but are not limited to, testing community-level preventive strategies to address COVID-19 related mental health disparities, developing and testing community-level preventive interventions to increase resilience and reduce risk for mental health disparities, testing community-level interventions to address social determinants of health and their impacts on mental health, mental illness. Examples include, but are not limited to, strategies to mitigate the effects of pandemic-related challenges, such as extended unemployment insurance, meal distribution, eviction moratoriums, et cetera. Testing community-level interventions designed to promote access to prevention services or access to mental health treatment as appropriate. Examples may include, but are not limited to, expansions of telemental health or access to technologies to facilitate telemental health. Evaluating policies or practices that allow for improved delivery of or linkage to preventive health services or mental health treatment as appropriate within public systems, such as child welfare, justice, schools, communities, and evaluating changes to school policies and practice, such as resource distribution, disciplinary practice, access to services during pandemic-related closures and quarantines to reduce mental health disparities. And we have, now I'm going to hand it over to Dr. Ismond.
Next slide then. This is Deborah Ismond. I'm an SRO, and SROs are often on the other side of the curtain, so to speak, in terms of describing what program intentions are, and then recruiting reviewers to come in and look at the applications you all will submit. So if I can have the next slide. I want to go over just briefly what the purpose of peer review is, because you're getting ready, you're hearing all this information, and you're going to be preparing an application, and then it comes in, what happens to it? And so our process involves recruitment of experts from the field to come in, and we have been sitting around the table previously, but sitting around Zoom like this meeting of late due to the COVID pandemic. But our purpose is to see the grant applications that are submitted are evaluated in a fair manner with independent and expert advice and evaluation free from inappropriate influence, so that the most promising research can be funded. Now, submitting an application to an NIH institute can be pretty daunting. I don't know how many of you are old hands at this, or this is a new experience, but it's a very competitive process, and reviewers tend to, get very involved in the details. But we also try to make sure that as SRO, I advocate for fairness, for getting rid of any kind of bias, and so on and so forth. So that's the first level of review. It comes before a panel of experts who have experience with some of the methodologies or disciplines involved with the populations that are being addressed. That's the first level of review, and we'll go through the process a little bit in terms of details. And then the second level of review is at the council level of the institute or center. So that occurs several months after the review period. And then any kind of funding decision is made by the IC director in consultation with program. Next slide. So I want to emphasize that I'm on the other side of the curtain in terms of peer review, because all aspects of peer review are considered confidential. It's conducted as a closed meeting. All the information and materials involved are considered privileged communications, and information about the discussion and who's been assigned, all that information is considered confidential and protected. So there's no disclosure really of any information regarding the outcome review, except what you will get in terms of your overall impact score and your summary statement. Then you will have a contact information about the program official that you can get in touch with. And next slide, please. So what happens to your application when it comes in? These are just some things I want to remind you of if you are planning to submit an application. Make sure that you understand all the requirements, the deadlines. Make sure that you have some people on your red team to review an application before you submit it, to make sure that all the T's are crossed and I's are dotted. Like I said, it's a very competitive process, and making sure you have a complete application and have followed all these guidelines that have been talked about and that are contained in the RFA. Once it comes into NIH, because it will be submitted electronically, it goes through the Center for Scientific Review, which is the standalone institute that is typically responsible for all applications coming in. However, some of the agencies have their own review branch, which is what I'm associated with. So there can be problems with submission. So whenever you submit, make sure you check it online in your folder to see that it's complete before the deadline. Because then after the deadline, you can't really change anything. And it could be, it's reviewed for completeness. So if it's not complete, it gets withdrawn. Program officials also have a chance to look at your applications before they come to the review meeting. And this is a way to make sure that what you're proposing is in line with what they've been suggesting in the presentation earlier and also in the RFA itself. And then the review process occurs once the application is assigned to the review group and the SRO assembles the review panel. Next slide. So do you have any contact with the SRO? Typically not, because I'm on the other side of the screen, so to speak. But information about the review date and the SRO should be in your grant folder under the grant information. You will be able to check the SRO if 30 days before the review meeting, if there is some kind of important information that is allowed to be submitted that might be relevant to the review. Say you have a publication that's been accepted or that has been newly published, or you received a grant award. If it's appropriate to the review, to the proposal that you've submitted, that can be allowed to be submitted as a note in the grant folder. So you would contact me as SRO or any other SRO. But for this particular meeting, it would be me, of course. Then following the review meeting, you will be able to see the composite scores. Those are typically released right after the review meeting. So you can usually contact the SRO to ask to come out, but typically it's within a day or so of the review meeting that the scores, composite scores, are released. And that also should be available in your grant, with your grant application folder. After 40 days after, you will receive your summary statement. And that is the only official record of the review process and the results of reviewer recommendations. It will go through the actual discussion points and what the conclusion was in terms of the overall impact of the grant. And review is typically a reductive process. So we're looking at a bunch of applications that come in. We're trying to divide them up into the ones that are going to be the most high impact overall in terms of what they're proposing. Also on the summary statement, there will be a listing of the program officer who's been assigned to communicate with you if they go forward to funding. So next slide. This is a bit of a description of the components of peer review. There's a panel that's recruited by the SRO. It's made up of people with expertise. There's a chair who runs the meeting and is responsible for making sure that there is a good discussion and that there's good calibration of scoring. We also make use of the NIH system, which is the same system you'll be submitting your application to. And we use that in communicating with our reviewers so that we can all get access to the confidential information provided. I also want to point out that Section 5 of the RFA is also what we use and give to our reviewers when they're reviewing applications. So it's very important that you read the fine points in that Section 5 of the RFA. I don't know if people have a copy of that, but that's what you're responding to when you submit an application. And this is a little tip that I don't know how many people are aware of, but Section 5 is programs, recommendations to the review people and to therefore the peer review panel, how they should evaluate the same information in section 5 also is the structure of the critique templates that the reviewers use to write their comments. And typically they go through each item, which are spelled out in advance, and write down what they think are strengths and weaknesses. And then there's scoring. Scoring is based on the NIH 9-point Likert scale. And that's used for evaluating, providing a score, and also as a reference for calibration. The peer review meeting is an opportunity for the reviewers to compare notes, to discuss differences of opinion, as well as make sure that we get a well-rounded input from all the different points of view, or ask topics, methodologies, analytic plans. There's a lot of moving parts in an application as complex as these are going to be. And then all that boils down, like I said, to one final score, and that's your overall impact score. And they typically are put in those 3 bins I was telling you about. It's going to be of high impact, medium impact, or low impact in terms of potential for execution in the real world, and having a sustainable, important impact on a particularly important, significant issue. Next slide. This is just to sort of give you some sense of how we advocate for our applicants in terms of ensuring that peer reviewers understand their responsibilities, that the process is protected, that confidentiality and non-disclosure are maintained, that conflicts of interest are identified and accounted for before anyone is assigned an application, that we ensure a thorough and fair review of every application that's submitted. And that means that even those that don't get discussed in the actual review meeting receive at least a summary from 3 reviewers, 3 assigned reviewers that you will get in the summary statement. And finally, the core values of peer review are expert assessment, transparency, impartiality, without bias, fairness, confidentiality, security, integrity, and efficiency. Next slide. This is the research criteria that we use. And again, this is found in your section 5 of the RFA that you're going to be writing your application to. So these are the NIH research criteria: significance of the proposed application, the investigator team that's been compiled, how innovative the project is in terms of the objectives, the approach. The approach is a big one because it involves all the moving parts of how you're going to do it, what's being done, what your analysis plans are, what your conceptual model is, what your metrics are, and then the environment in which it's occurring. And that's, in this instance, going to include the relations with your community partners, the roles that community partners will be playing, especially if there's an interest in sustainability. That means how the intervention can be continued over time, perhaps. Additionally, there are some scoreable criteria and then non-scoreable criteria, which are also spelled out in your section 5, the RFA. And then there's an option to submit a clinical trial as your part of your proposal. Those sections on clinical trial have very specific instructions. I know that Eve was talking about how NIMH in particular would like to have people focus on their requirements for clinical trials, but there are also additional clinical trial requirements listed in section 5. So make sure you read the fine print and go through and sort of list all those things that are going to be relevant for the application you're submitting and putting together. So all these things are things that I need to brief the reviewers about before they start their review of your applications. Next slide. These criteria that I keep talking about in section 5, I actually go through and pull all these things out and make a little handout for the reviewers. You could do the same thing for yourselves, for your red team, for the different team members who are pulling your application together. Make sure that you read all that fine print. Next slide. The critique template, as I mentioned, follows that same format that's in the section 5. We go through and evaluate what's there based on the tips that are put in terms of the section 5 comments under each of those 5 review criteria. And we put them in terms of strengths and weaknesses, how we see an application in its entirety for the different areas of research criteria, the 5 review criteria. After that, we come up with an overall impact assessment, which is basically a summary of how well we think the overall application will do in terms of if it's actually implemented. And I mentioned that a couple of times, but that's usually constructed and put at the top, but it's something that usually occurs at the last and is associated with that final score. Next slide, please. This slide just sort of shows conceptually how we relate the 2 aspects of the 5 NIH group review criteria, which again are associated to all those specifications in section 5 of the RFA. So 5 criteria, we go through, we evaluate strengths and weaknesses. Then we use the NIH Likert score to come up with a number, and it's a reductive process. And then after that, we come up with an overall impact score, high, medium, or low. And that's going to be what's reflected in that composite score that's submitted or released after the review meeting, followed by the complete summary statement once it's released. Next slide. So this is a bit of an overview just for people who don't really have experience with the peer review process. A lot of reviewers are familiar with the process or come in, after 2 times and they're old hands at it. But I get feedback. They say it really helps them understand how to put a grant together. So we thought it might be interesting for some of you to at least understand that. In closing, make sure that you have people, whether it's your team or outsiders who are experienced with NIH research grants, go over your application before you submit it. Make sure that it's well organized, that it doesn't have typos and missing sections, because those kinds of errors will just reduce its overall likelihood. There are resources on grant submission, on pulling your grants together, how to submit it, and if you have any issues with processing, because sometimes our system can get a little overwhelmed or temperamental. And again, that's another reason why you don't want to wait till the very last minute. Make sure you submit it in time so you can check it and make sure that there's no missing pages and sections that didn't go through your copier or something like that. And then there are some training videos that are available at these references, and as well as other places. I'm sure you can finding people on your team or through your other associations who have experience with NIH grants, submitting research grants, would also be good as advice too. That's it. Crystal.
Okay. Thank you, Dr. Isman. Thank you, Deborah, for that overview of the review process and some tips for review. So I'm going to talk now about some timelines. Next slide. So the letter of intent was due on February 28th on Monday. It was encouraged, not required. So not to fret if you did not submit a letter of intent. That was So that's passed, but that was on February 28th. Applications are due on March 28th, so in a couple of weeks. And there is just one due date, and that as of now, that's one due date on March 28th. The peer review meeting will be held sometime in July. The peer review meeting that Deborah described in detail, that's currently anticipated to be held again sometime in July. And then applications will be reviewed in council sometime in August with an earliest start date for reviewed and accepted funded applications sometime in September of this year. So that is our timeline for this RFA and for how this process will flow. Again, it's moving very quickly, as we know and are aware, but we are very excited about it. So with that, let me go to the next, let's go to the next slide and just provide you with the NIMHD contacts. Again, I am the program scientific contact for NIMHD. So if you have specific questions about applications scientifically or the research, please do feel free to contact me. Questions about peer review can be directed to Deborah, and then questions about grants management or financial questions can be directed to our Chief Grants Management Officer, Priscilla Grant, at the number or email listed here. And contact information for our other colleagues and other scientific research contacts are listed in the RFA. So with that, I would like us to turn it over now, and let's maybe field some of the questions that have been entered into the chat. I think we have a few, but if you do have others, please feel free to list them in the chat. And I would invite my colleagues to come back onto the camera as we start to entertain some of participants' questions. So let's see. Scroll here. Looks like there's a question about the only date you see listed with regards to the due date is March 28th. That's correct. At this time, no, there's no plan in terms of reissuing the RFA. Let's see. Yes, the slides and a recording of the webinar will be available after the meeting and will be available on the NIMHD's website. Okay, I have a question for the team, probably maybe for Deborah. How much added value will be given to a proposal with clinical trial versus no clinical trial?
This is Deborah. If you choose not to submit a clinical an application that includes a clinical trial, it doesn't weight the application differently for one with the clinical trial. It's just talking about the components that are needed if you're going to propose a clinical trial. So,
can I add something there, Crystal?
Yes.
Yeah.
Yes.
So just to emphasize, and this is related to my office, ODP's interest in co-funding. So the issue is really about, is it better to do a clinical trial or not? The question is really, because the RFA is focused on testing prospective interventions, not interventions that are already going on, what is the best study design? It's possible that the best study design to test a community level intervention may not actually have individual health outcomes on people. And so it doesn't qualify as a clinical trial. Let's say it's looking at county level violence outcomes or emergency department visits or something like that. That may not qualify as a clinical trial, but it's an appropriate study design. Note that if you are not testing a prospective intervention, that would actually be non-responsive.
Thank you, Jennifer. But again, in terms of, so there are questions, so there's some considerations about the appropriateness relative to testing a community level intervention. And then there's questions though about kind of the weight of proposal of doing a clinical trial versus not. Okay. Another question, the RFA states, investigators who wish to evaluate the effect of an intervention on a health-related biomedical or behavioral outcome may propose a study in which groups or clusters are assigned to study arms or individual observations are analyzed to evaluate the effect of the intervention, or participants are assigned, so talking about group randomized trials or step wedge. And so I think, let's see, the question, does this then count as a community level outcome measure, or is it just allowable?
Can I answer that one too, Crystal?
Yeah.
This is boilerplate language that actually
Right.
derived from my office, the Office of Disease Prevention. And it actually is not, so that means it's part of the template. It wasn't written, like it's included as part of every clinical trial funding opportunity announcement, but it wasn't applicable to all kinds of clinical trials. So actually this required language has been removed. So I would recommend you pay more attention to the expectations and the review criteria related to study designs and study outcomes.
Okay, thank you.
This is Deb. One more comment from the review side. It's really important that you have a good conceptual idea, a conceptual model, and some idea about how the metrics are going to, what the metrics are going to be. So like Jennifer was talking about, what it is you're going to be looking at to determine outcomes. So it's really important that you get those sort of research questions and the flow of the information and the analysis, as well as how it's being captured in terms of the metrics.
Thank you, Deborah. We have a project to implement, but do not have the research component. Is there a way to connect with a skilled research partner? That sounds like a specific question. I would suggest that individual you contact the scientific research contacts. It sounds like you're asking about connecting with a skilled research partner, but I think that's a very specific research question. So perhaps that's something best addressed individually. So my suggestion would be to connect offline with one of the contacts. So you can feel free to contact me. Okay. Can you say more about individual or community level outcomes if the intervention beneficiaries are community residents?
Do you want me to jump in, Crystal?
Yeah, sure.
Okay.
Right.
In thinking about things that my office might be interested in, even though the determinants or the mechanisms of action are meant to be community level, it's possible to look at outcomes at different levels. So let's say, for example, an intervention was aiming to improve the food environment in neighborhoods by working with the owners of corner stores to change the food options available. Outcomes could be at the community level, so looking at food purchasing practices in neighborhoods with and without this intervention, that would be community level. You could also enroll participants in the different communities and ask them about their dietary practices and their food purchases and their fruit and vegetable intake, for example, as a individual level. So for any community level intervention, there's going to be a variety of different outcomes that could be assessed.
At the individual level.
At the individual level, right? So, but also the higher level. So it's not the community level determinants. In my office, would be looking for applications that really address the community level determinants, but the outcomes could be at any level that are related to health.
Can I just follow up on that really quickly?
I'm sorry. I'm sorry. Could you enter your question into the chat? Thank you. Okay. Nope, the next question, nope, the deadline for the letter of intent was the 28th. But if you have a specific question, feel free to reach out to the one of the scientific contacts. If there's a no cost extension past the 5 years, can funding be carried over beyond 5 years? That sounds like a grants management question. So I would direct you to contact our grants management contacts. Next question, given community level interventions, which often rely on existing community partnerships, I just lost it. How important is intervention randomization versus just using a comparison community? So I can jump in, and then again, I would invite my colleagues to answer as well. Again, I think part of this is the desire to understand the impacts and rigorously testing the impact of the intervention as rigorously as possible. Again, within the confines of using and within the parameters of using community engaged research approaches. And so again, there are considerations that have to be made as we've discussed. So I think it's important that you do so kind of in making those decisions. If you can randomize and do so rigorously and do so with fidelity, I think that's kind of the aim, and that would be the goal. Again, and rigorously being able to test the impact of the intervention. Again, meeting the needs of the community and maintaining the engagement of the community. But I think, but there are some considerations and kind of balances that need to be adjusted and need to be made. And so, for me, that's kind of those are the decision points that we're aware of and that we're understanding and looking for. Jennifer or Eve.
Yeah, just echo, we would be looking for the most rigorous study design possible, given the considerations of the study question, what is feasible, practical, ethical, and what I think for co-funding for my office, something that's a pre-post single community study would not be a priority for co-funding for my office. So we would be looking for the multiple communities to be included in a project.
Eve, you're on mute.
Thank you. I agree the need to provide the most rigorous design possible and to provide a justification for the design proposed.
Okay. Is the budget 1 million direct costs per year or over 3 to 5 years? It's per year. Okay. For the NIMH priority areas, is the focus the same as overall on community change intervention? For example, for the case given of telehealth or other interventions, or in that case, is the community focus either input or the population focused on or system change?
For NIMH, the priority is the same as for the overall RFA. So NIMH does not have a different priority than any other institute involved in the RFA.
Okay. As a follow-up, can you elaborate on going beyond individual self-reports? Is this specific to primary outcome? And can primary outcome be self-reported, but secondary outcomes are objectively measured? So yes, this is this is specific to primary outcome, going beyond individual self-reports, again, in measuring and thinking about and measuring the impact on the community level determinants. And so not just relying on, not simply relying on individual level self-report data to measure the impact on the primary outcome, the primary health outcome. Okay. Can you explain a bit more about the community size, minimum number of community residents? So I don't, there is no, from my kind of perspective, there's not necessarily a magic number in terms of community size or minimum number in terms of community residents. Again, especially with regards to how we are conceptualizing and defining community. Again, so I think it's in how you are, one, identifying and operationalizing your research questions and considering the intervention to impact a particular community, whether it's an entire population within a specific community or a subset within that community. But there's no kind of parameters with regards to a minimum number of community residents. But again, that goes back to the study design and how you are most rigorously testing the impact of the intervention. So minimum number does come into play with regards to the design and thinking about how you are developing your design and testing the impact of the intervention. But community size is defined by the community. Jennifer or Eve, do you want to add to that or maybe amplify that a bit more? I don't know if you have anything to add to that in terms of community size.
Yeah, I would agree with you, Crystal, that it really does depend on what the research question and topic is. So it's not related to size, but it is related to it could be self-identification of a community. It could be identified neighborhoods that are served by a certain school district or public hospital. So I think like Eve was saying about the study design, we would be looking for a justification of a description and justification of the community and how it'll be used, how it's conceptualized in the project.
How do you define perspective research design. I think, and please add in here or kind of amplify your, or maybe clarify your question. Do you mean the prospective intervention? You can feel free to add in the comment, but prospective research design. A research design that is focused on prospectively that design that is focused on a testing of an intervention that has yet to be implemented versus that has previously been implemented. That's the focus. It's not on an already implemented or already kind of to scale intervention, but really kind of one that is yet to be implemented or brought to scale. Is an intervention having iterative updates with input considered prospective, even if it exists in some form prior to the proposal? That sounds like a specific project question. So we can maybe we can talk a little bit more about that offline.
Just perhaps to clarify, this is not to say prospective doesn't mean brand new de novo. It could include the implementation of evidence-based interventions or practices tailored for a particular community, right? It just means the research is involved at the phase of the implementation of that intervention, not something looking back to something that's already started, that's ongoing, that finished years ago, right? That it's research that's moving forward from the implementation of whatever the intervention is.
So is an intervention having iterative updates with input considered prospective?
I would agree with you, Crystal, that I think that's about what do you mean?
So
iterative?
so I would say to that person, if you could give us, I think we have maybe a call scheduled or on the books, but if you could follow up with us offline so we could get some additional information and have a discussion. Modeling studies of future interventions, for example, population risk assessments using input data from community-based organizations would be allowed to be included. Again, that sounds like a pretty specific question. Please feel free to contact us so we could get some more information. That also may be dependent on study design and some additional details about kind of what's meant by input data. So please follow up with us about that. Again, specific questions, we're going to punt and have you contact us or ask you to contact us directly so that we can give you more attention and time and answer in more detail. Jennifer's, all of the other additional scientific research contact information, again, is available in the RFA. And again, with specific questions, more specific questions about a particular project, I would encourage you to contact the research contact. Okay. So it looks like I think we're about done with.
I think we missed one, Crystal.
These are they look more specific, Eve. So I'm going to ask these were kind of more specific questions. Unless you see one that's.
I think one is follow up on Jennifer's example. Should the community level changes in food practices be the primary aim and individual diets be secondary?
Yeah, that's a pretty specific question, and I would encourage that individual to follow up specifically with Jennifer. Let's follow up.
I can answer that in principle, I think, because it is on my example, not the study necessarily they were proposing. I think, so there's a difference between the mechanisms of action and then what outcomes are your primary outcomes. So if your mechanisms of action to change the nutrition of a community and your mechanism of action is changing what's going on in the corner stores, then you would certainly want to measure that as your mechanism of action. Whether you're looking at the corner store activity as your primary outcome or the individual diet, that is up to you and your team about what you choose to be the outcomes for any topic area.
Okay. I do see we have a couple more questions that have come in. Can you speak more about what you're looking for with regard to innovation? For example, if the intervention is based on a previously proven model, but if you are implementing in a different population, what innovations are you looking for? So what I can say from NIMHD's perspective is that, again, innovations that are, again, either somehow uniquely tailoring the intervention to a population that is experiencing health disparities with appropriate evidence and justification. And again, in a rigorous way, and kind of testing that in a rigorous way, and utilizing innovative or different approaches in the delivery of that intervention, excuse me, in doing so. Those would be some of the types of innovations. So again, thinking about the population and the community and how the intervention is intended to not only make its impact, but how it's to be delivered.
And there could also be innovations in methodology as well.
Deborah, I'm just reading from the RFA. Does the application challenge and seek to shift current research or clinical practice paradigms? For example, utilizing novel theoretical concepts, approaches, or methodologies, instrumentation or interventions. Are the concepts, approaches, or methodologies, instrumentation, or interventions novel to one field of research or novel in a broad sense? Is a refinement, improvement, or new application of theoretical concepts, approaches, or methodologies, instrumentation, or interventions proposed? So look through the section 5, people.
Thank you.
Thank
Deborah.
you. That's very helpful.
Yes, thank you, Deborah. All right. Again, I would encourage you to, with specific questions about your project, strongly encourage you to reach out to any one of us and schedule a time to talk or to ask questions. We are available, and we will be happy to reach out to you and speak with you. And certainly, again, reach out, use your resources to be able to answer any other questions, both related to scientific or research content, but also grants management or review as well. We have one more slide. No, okay. And so with that, I will thank you all for attending. Again, this will be posted on the NIMHD website, and we appreciate everyone's attendance and questions. And again, I thank my colleagues for their attendance and participation.